persistent hypoglycemia, initial managements, and targeted therapies.
On yours.
Where do I click? There we go. Got it. All right, we're going to start with a little case, as we do. 65-year-old Taiwanese female with unknown past medical history brought in by EMS for altered mental status in the field. His finger stick was 17 as reported by EMS. He got 1 amp of D50, came in. His vital signs now are within normal limits. You can read it if you want. His physical exam, what's important is he's now ANO times 3. You see an abrasion on the right temple. You call Seracom for some more information and they tell you to stand by. This actually happened to me in CCT. Just couldn't talk to a patient at all. They didn't call back for like 30 or 45 minutes. So just kind of have to work based off of what you're seeing. First, I want to go over Whipples Triad. Not sure how useful this is. I think it's pretty intuitive for us, but we do mention a lot in literature. It's where you have symptoms of hypoglycemia, their finger stick is low, it gets better when you give them sugar. That's it. So, someone put their name on it. I don't know. They just wanted to.
Damn, I should have thought of that.
I know. There's probably more things out there like that if you want to.
When I initially saw that, I thought it was pretty stupid too, but I think the important thing to remember is if you're attributing symptoms to like a mild hypoglycemia, like 59 or 60, and you give them sugar and they're still dizzy, you can't just attribute to like, oh, they were probably just hypoglycemic to 60. I think that's where it's important. On the other side of it, yeah, it's pretty common.
Yeah, I thought it was intuitive, but that's true. So a lot of papers I was looking at was trying to split it up into hyperinsulinemic hypoglycemia and hypoinsulinemic. I was thinking of it more like hyperinsulinemic versus not hyperinsulinemic because you're not really hypoinsulinemic necessarily. You're just not hyper. So I like tables. There's a lot of tables in this. I'll go through this step by step. First, we can talk about insulin overdose, self-explanatory, too much insulin, either medication mismatch where they gave themselves too much, they didn't eat. I go through a couple of other causes on another slide. Gluconeogenesis isn't really affected. That's not the main part. Glycogenolysis also isn't. Next one, we have adrenal crisis. Here, insulin isn't so much the problem. It's that there is no gluconeogenesis, no glycogenolysis due to low cortisol. Next, hepatic failure. Insulin, there's more insulin actually circulating because it's not being metabolized by the liver. It's not necessarily hyperinsulinemic, it's more relative hyperinsulinemia. Low gluconeogenesis due to injury in the liver and low glycogenolysis as well. Renal failure, again, it's more relative. There's decreased metabolism of the insulin, decreased excretion, and that's actually only exogenous insulin, I believe. So endogenous is typically metabolized by the liver, exogenous is by the kidneys. The rest is not affected. Also, interestingly, treating potassium in end-stage renal, I saw a couple of papers that show pretty high rates of hypoglycemia, even with giving 50. I think the rates were 13 to 18%. There was one paper that showed a rate of 75% in end-stage renal disease. That wasn't what most of the numbers were, so I would stick with like a 13 to 18%. And most of that happened about 2 hours after giving the insulin and persisted for 2 hours after that. Sepsis, that's secondary mainly to multi-organ failure. So having hepatic failure, renal failure, so you're going to see all of the above. Finally, alcohol binging. It's when you don't eat for a couple of days, you're just drinking alcohol. Glycogen stores only last for 2 days. After that, you're relying on gluconeogenesis, and that is impaired due to alcohol metabolism. So, yep. When there's a medication mismatch, when you have a patient who you know is diabetic, who's on insulin, it's important to figure out why they became hypoglycemic. It could have been just a mistake where they gave themselves too much, weren't wearing their glasses, but it could also be that they're starting to not eat as much in the last couple of weeks, malignancy. There's a couple different reasons. You want to kind of suss out what that is so they don't just end up back in your ER hypoglycemic. Otherwise, if they're starting to get on a better diet plan, exercising more, they might be more insulin sensitive. They might need to go back to their PMD to get different insulin regimen. nausea, vomiting, and again, the alcohol. Adrenal insufficiency, a couple causes, acutely sepsis, glucocorticoid therapy withdrawal is one of the most common for us. Hemorrhage, otherwise more chronically, I think TB is one of the leading causes of adrenal insufficiency, primary adrenal insufficiency worldwide. Infiltrative diseases, autoimmune. If it's primary, you'll see low sodium, high potassium. If it's only secondary, you'll see low glucose secondary to the cortisol. So here, initially, I think this is pretty self-explanatory too. First, we give some form of IV dextrose, repeat finger stick immediately 5 to 10 minutes after that. If they're less altered, think about Whipples Triad again, if they're less altered after that, you want to feed them PO, some complex carbohydrates. If they're not less altered, you want to think about your differential again. Also, I had I think the reason I chose this topic is because I had 4 persistently hypoglycemic patients kind of in a row last week. 2 of them, I never fed them. They came in after getting D50, and they both dropped back down to 45 or 30, about half an hour afterwards. So if they are able to take PO, you want to give them something that's going to sustain them a little bit longer than the D50 is. There's a couple of different thought processes on what you give initially. You can give D50 IV push. It can blow the line though. The osmolality is pretty high, 2,500. They suggest giving anything above an osmolality of 900 through a central line. So you don't want to be repeating that too many times. Throat veins, cause thrombophlebitis. Otherwise, it'll 1 amp of D50 is 25 grams of sugar. It's in 50 cc's. It'll up your finger stick by about 200. That's pretty dependent on the patient's weight. It takes about 8 minutes. In a study they did pre-hospital, it took about 8 minutes for people to go back to a GCS of 15 after being altered. You can give D10 as an IV push. Obviously, you're giving higher volumes then. It's pretty time consuming for the nurse to stand there and push it. You're supposed to push over the course of 2 to 5 minutes each amp. So that's not always realistic. You can also hang a D10W bolus strip. Put it in a pressure bag. It'll go in pretty quickly as well. And then you don't have someone standing there. You're less likely to blow the line. And it's the same thing as giving it push, except you're not the one just standing there pushing it. Otherwise, glucagon, I know we learn it at least in pre-hospital and EMS protocols. You can give glucagon IM. It's not such a great idea if you're giving an altered patient glucagon. Sometimes they vomit, they aspirate. Otherwise, if they're not altered anymore and you give it, they just get nauseated. It's hard to orally. It takes 10 to 15 minutes to kick in anyway. It's risk benefit. I haven't seen anyone give it. I can't think of a reason you would give it if you can't just give D50 or D10.
Can't get a line. You can't get a line.
Can't you just get
You can't get oral.
an IO line?
It's given on the floors a lot because it's IM. It's very
Yeah.
easy if the IV is blown.
That
You
makes
can
sense.
give D50 IM too.
Yeah?
Yeah.
There you go.
That's a big line.
No, okay.
Throw unconscious.
Jury's out. Okay. I only want you to take away from this that insulin stays in your system for a long time. D50, 30 minutes. So you need to keep checking your patient after you give the D50. It's not going to be enough to just give them 1 amp and walk away, especially if you're not feeding them. So it doesn't matter how long necessarily, but depending on where you are in the time course of when they took the insulin or got the insulin, you're going to have to keep an eye out on them for a little bit longer. Special targeted treatments, if they've had a sulfonylurea overdose. Sulfonylureas increase endogenous insulin release. Octreotide blocks endogenous insulin release. So that is what you would give specifically in that kind of overdose. If you know the patient has a history of taking those, you can load them with 100 micrograms, and then every 6 hours you do 50 mics sub-Q. You would persistently do this for about 24 hours because that's how long sulfonylureas stay in your system. Interesting side note, if you have a pediatric patient with an accidental ingestion of even just 1 pill of sulfonylurea, they have to stay for OBS for 24 hours. Adrenal crisis, there's decreased cortisol. You just give hydrocortisone because it replaces the cortisol. Yep, and you can give 100 milligrams Q6 hours. chronic alcohol use, they have decreased thiamine due to poor intake. Thiamine is one of the cofactors for glucose utilization. So you want to give them a dose of 100 to 200. Some studies say theoretically prior to actually giving the dextrose. It's really if you're giving sustained doses of dextrose that you need to give it prior to doing it for a long amount of time. Just as long as you give it at some point around the time that you give the dextrose. And it doesn't need to be the full 500 dose for Wernicke's. When to get labs? If they're severely hypoglycemic, if they're altered, if you don't know what's causing it, multiple comorbidities, or they've had frequent visits to the ED for hypoglycemia. So basically all of our patients. If they're there for it, they're going to be sticking around for a couple hours anyway, get some basic labs. Which labs? Mainly it's CBC comp. You're looking for the hepatic failure, for kidney failure, maybe the sodium cake can tell you a little bit about adrenal insufficiency. I don't know how useful that really is. Suggestions, beta-hydroxybutyrate can kind of give you a hint on whether it's not a hyperinsulinemic state or not, because insulin tends to block ketone production. So if you have a bunch of ketones, it's unlikely to be that. You can look at thyroid function tests if you think it might be associated with a hypothyroid or a mixed edema. Otherwise, random cortisol levels, again, maybe not super useful, but if it's very low, then that can give you a hint as to what's included in the process. Otherwise, your patient needed to get a head CT because we can't understand him. He has an obvious abrasion. He's found down. Still, Sauerkraut hasn't called you back. So he went to CT. He hung out in the hallway for a little while right outside of CT because there were a couple stroke codes that came back to back. He comes back in. He looks super diaphoretic and altered. Repeat finger stick is 27. This happened. Yeah. Now you can start thinking about a drip. D5W or D10 drip, 75 to 150 mils an hour. And then consider giving hydrocortisone 100 Q6. So you can give it regardless of what the etiology of it is. It can help you titrate down the rate of the D5, D10. Many of our patients are fluid overloaded or end-stage renal, so you don't want to be giving them maybe too high rates of a drip. You can manage that with giving hydrocortisone. It'll decrease that amount. It'll also decrease the amount of electrolyte shifts that are happening. That's what I saw. Okay. Great. Disco. So I've had a couple of problems with this particular patient situation. MICU tends to reject them, but you do need somewhere that'll do Q1 or Q2 hour finger sticks. I've heard of patients going to the floor. They weren't able to get the Q1, Q2 hour finger sticks. I think they stopped the dextrose. The patient got altered. It wasn't a great outcome. So for these particular patients, the best situation would be a step down. We don't have step down. So MICU, I think, is the most appropriate place to try to push for these patients. They do really need those finger sticks. Yep, that's it. Thank you. Any questions, comments? Did I say it wrong?
Center did a study on this, labs and hypoglycemia.
So dialysis patients with hypoglycemia, if these patients see there's a thing called malignant hypoglycemia in dialysis patients. So dialysis patients without taking insulin, without taking sulfonylureas, without taking any other cause, you probably should admit them for at least 24 hours. There's a 50% in-hospital mortality rate for malignant hypoglycemia. So dialysis patients with hypoglycemia, you should always admit.
The other, since you brought this up, is patients that you're treating for hyperkalemia with insulin and D50. Just remember that insulin in these patients lasts a long time, even regular insulin IV, because the kidneys are used to excrete insulin, and you don't have kidneys, it's going to stay around. And I have seen several cases of people who were treated for hyperkalemia with D50 and insulin, and an hour or two later become very hypoglycemic. So So you want to really watch them closely for those first few hours and repeat the finger stick, and if need be, repeat the 50s or hang and drip, although in these patients, you can't give them too much fluid. So you have to be careful with that.
Yeah, so that's actually 2 of my patients in the last month. One of them we gave, I think, just 5 units of insulin, and we gave 2 amps of D50. And he still became hypoglycemic pretty severely.
Yeah, when I have that, whenever I treat hyperkalemia with insulin, I write an order. The nurses don't like it, it's downstate, but I write an order to check the finger stick every hour for the next few hours.
Yeah.
I think that's the reason why I always get labs on these patients, because you commonly can have renal failure, not uncommon, because the result is renally excreted, so if someone goes into renal failure, we have this. Another lab you can order if you're admitting, just for the admitting team, is C-peptide level. They always like to do that to see if those C-peptide level is effect or low.
Cleave fragment.
Yeah,
So if it's not there, it's an insulin model.
Yeah, exactly. If you have a lot of C-peptide, then it could be an insulin. It's very rare. But we've had a few patients here over the history of downstate in Kings County with diagnosis of those surgery second. So and they'll know that history. But we have seen that they're very rare.
Especially in peds. Peds, the 1 chance of approximately.
Yeah. I've had a lot of patients with hepatic malignancies that end up having persistent hypoglycemia. They also have masses in the pancreas. I was always curious about whether it could be an insulinoma, but it's just what it is. It's just the hepatic failure from the tumor burden. So that I've seen a bunch too. I actually have a quick question for Dr. Sinner. Some consultant possibly told me that insulin IV doesn't stick around in patient for very long in end-stage renal disease. That doesn't
No.
seem right to me,
It's just the opposite.
right?
25% of insulin metabolism is in the kidneys,
Right.
so it stays much more.
That's what I thought.
Yeah.
Okay.
Yeah, 30 to
Just making
80%.
sure I know what I'm
getting.
doing.
I just looked it up.
Okay.
So it's much longer.
Someone in the chat, Naomi, said you could use glucose. It's in the Pyxis, which is like a gel. And then
So Naomi in the chat said that you can use a gel, I guess, in the Pyxis.
yeah, we have that, right? Glucose.
Glucose?
The sugar gel. If they're hard IV access.
It's like a super sweet like gel that you can take.
It's marathon.
And you just put it in the gun.
When we go camping around
Yeah, or
hiking, I take it with me just in case.
On the gun,
I
yeah.
don't know if it's any better than just the tuna fish sandwich at County though. That's got a lot more I think, complex carbs that the gel packs have.
Yeah.
So I like the power of the tuna fish sandwich.
I think it's just more aspiratable. It's not such a push to.
They actually did a study on what is the best thing to give them once they come back to me. And the best thing was turkey with a ham, cheese, and sandwich. It was the best thing once they're over.
So they did a randomized study on